Welcome to AETCM, the emergency medicine channel. Today let us discuss about causes for acute liver failure and mainly viral hepatitis. That is one of the major cause for acute liver failure in our country. Other than that, drug overdose or poisoning, all these things can also produce acute liver failure. It is characterized by acute liver injury, hepatic encephalopathy, and elevated PT-INR, prothrombin time and INR. The time taken for all these problems like liver failure, hepatic encephalopathy, elevated PT-INR, all should be within less than 26 weeks. So it can again be divided into hyperacute less than 7 days, acute 7 to 21 days, or 21 days to 26 weeks, that is subacute. That is a subdivision of the acute liver failure. The patients with hyperacute or acute liver failure, brain edema is a very important finding. That's why we can see them, many of these patients will be comatose or they can have features of hepatic encephalopathy. But it is not very common in subacute type of liver failure, but ultimately, eventually they develop all the problems because of the liver failure. Previously, it was referred as fulminant hepatic failure, acute hepatic necrosis, fulminant hepatic necrosis, fulminant hepatitis, but all these things are similar. This is a more recent name is acute liver failure, and according to the weeks or days, it can be subclassified. Now, what are the causes? One of the most common cause all around the globe, that is paracetamol poison, paracetamol toxicity, the overdose of paracetamol, that is very important. Some drug reaction, idiosyncratic drug reactions, that is not dose dependent, whereas paracetamol is a dose dependent liver failure. Then viral hepatitis, hepatitis B, C, D, E, A, all can produce, but more common in hepatitis B or sometimes A and E. Alcoholic hepatitis not very common because most of them are chronic alcoholic liver disease patients, and acute and chronic liver failure is more common. At autoimmune hepatitis, very common in young females. Wilson disease, ischemic hepatopathy, that is mainly occurring after hypotension, shock, acute cardiac arrest, all these things. Budd-Chiari syndrome, that is a veno-occlusive disease. Acute fatty liver in pregnancy, HELP syndrome, malignancy and the infiltration of malignant tumors to the liver, toxins, mushroom poisoning, rat poisoning, sepsis, heat stroke, and macrophage activation syndrome. So, these are the common causes for acute liver failure. Now, you look at this chart, you can know about different types of hepatitis. So we have hepatitis A, B, C, D, E. In that, the spread is mainly hepatitis A and E is foodborne or waterborne, whereas hepatitis B, C, D all are bloodborne. So, there is a major difference in spreading. And chronic infections are very, very common in hepatitis B and C. It is not very common in other types of hepatitis. Prognosis is very good in hepatitis A, hepatitis E, but hepatitis E can produce complication during pregnancy, whereas hepatitis B and C and D is always associated with hepatitis B. There will be a chance of chronic progression in the patients who is infected with hepatitis B and C. So, chronic carrier state or chronic progressive hepatitis is common in hepatitis B and C. Severity, hepatitis A and E are not very severe, B is also not severe, but sometimes it can become very severe. Fulminant hepatitis is very, very common in hepatitis D, and it can occur even in other types of hepatitis. Remember, hepatitis E in pregnancy can create problems during the pregnancy. Cancers, hepatitis B and C can produce cancers in the patients who is having hepatitis B and C chronic infection. treatment, hepatitis B, interferon, lamivudine, adifavir, entecavir. Most of these drugs are anti-HIV medicine. So, many patients can have hepatitis B and HIV co-infection. So, these drugs will be helpful. C, pegylated interferon plus ribavirin, and newer drugs have come. Treatment of hepatitis B is enough for hepatitis D. A and E, there is no need of any treatment for hepatitis B and E as such, but supportive therapy like we will discuss afterwards. Now, hepatitis A can be prevented with vaccine. 3 doses has to be given, 2 doses has to be given, 0 and 6. Hepatitis B can be prevented, especially in healthcare professionals, 0, 1, 6 months we have to give the vaccines. And if post infection, post exposure, we can give immune serum globulin. Hyperimmune serum globulin can be given in both hepatitis A and B. Other viral infections, that is not possible. So, this charts will be very helpful to understand the different types of hepatitis virus infection. Now, what are the symptoms of hepatitis? Hepatitis can have jaundice, that is the most important finding, and in liver failure patient can develop ascites, and those who are having liver failure, because once the liver failure occurs, patient can have elevated PTNR, bleeding tendency. You can see lot of ecchymotic patches. So, these are the most important clinical finding. Now, what is this? This is flapping tremor. You ask the patient to hold like this. Normally from our joint, there is a sensation, joint position sensation will go to the brain. Here it will be interrupted. So, the patient cannot hold it hand like this, it slowly goes down. Okay. So, this is one of the important sign of hepatic encephalopathy. So, there are 4 grades of hepatic encephalopathy. First grade is the sleep reversal. The most important finding in the grade 1 is sleep reversal. So, that is sleep reversal. Second grade onwards you can see flapping tremors. Third grade you can see confusion, that is very important thing. Fourth stage you can see the coma. Okay. So, altered behavior from grade 1 to grade 3 is actually increasing. So, altered behavior is GCS is reduced from the grade 1 to grade 2. But there are some key points to remember in all these grades. Sleep reversal is the first sign, flapping tremor is the second sign, confusion is the third sign, coma is the fourth sign. Now, laboratory abnormalities, the most important laboratory abnormality seen in liver failure is the functional part of the liver. Okay, that means liver produces all the coagulation proteins in our body. So, if coagulation proteins are not produced in our body by liver because of the liver injury or liver failure, you can see INR will be slowly elevating. Panic level will be more than 1.5. So, normally INR will be 1. It is a normalized standard ratio. So, normally it has to be 1 or less than 1. But here the body is not having coagulation proteins, there is a chance of bleeding. So, you can see slowly the INR is getting elevated. So, that is very important. Then you can see platelet count will be low, that may be because of the infection or it can be due to some splenomegaly or something. So, depending on the elevation of SGOT, SGPT, you can have various conditions which produces liver injury. So, in hundreds, what happens? 100 to 300, what is a major cause? More than 1000, what is a major cause? All these things you can know from this chart. Okay. There are very few conditions which can produce very high levels of SGOT, SGPT. That is acute viral hepatitis, maybe the counts will be 10,000, 20,000. Ischemic hepatitis after cardiac arrest, hypertension, shock, drug toxicity like paracetamol, rat poisoning, and toxins. All these things can produce very high levels of SGOT, SGPT. Now, there are some investigations required in acute liver failure. One of the most common cause in our country which can produce acute liver failure will be toxins, including drug overdose. So, this is a nomogram that is called as Rumack-Matthew nomogram. If the line is above the standard line, then treatment is required. If it is level is above treatment line, treatment is required. So that has to be charted according to the levels. So that is done in paracetamol overdose. Then if the patient is having history of rat poison or some other poison which can affect the liver, toxicology screening of the urine, blood and aspiration is very important. Then Wilson disease, we have to check for copper and other investigation that we will see the next slide. If it is a young female coming without any reason, liver injury, then you have to suspect autoimmune hepatitis. So you have to ask investigation like anti-SLA, LP, P-ANCA, anti-DS-DNA antibodies, anti-liver kidney microsomal 1 antibody. So these are the things you have to ask. Now viral markers are very important. If you are suspecting hepatitis A or B, these type of viral markers you can see here. In hepatitis B, these are the investigations. Hepatitis B, these are the investigations you will ask. So that will tell you where is the problem. If it is an acute hepatitis or chronic, these investigations will tell. So that is very important, that investigation should be asked. Now other laboratory investigations, depending on the clinical scenario, hemolytic anemia can be there in patients, elevated creatinine and urea can be there because of the hepatorenal syndrome, elevated amylase lipase because of the sepsis or multi-organ dysfunction part, you can get that. Hypoglycemia is very common in liver injuries, hypophosphatemia, hypomagnesemia, hypokalemia, all these things can be associated with liver injury. Acidosis or alkalosis, depending on the condition which produces liver injury, can also should be checked. ABG should be asked. Elevated ammonia level. Remember, ammonia level will be elevated in the liver failure. Ammonia will be definitely elevated, but the elevation, that elevation range will not correlate with the severity of the hepatic failure. Sometimes the ammonia level will be slightly elevated, but the liver injury will be very high. Sometimes ammonia level will be very high, but the liver injury will be small. So that level will not tell you what is the severity of hepatic failure. That only tells you that there is hepatic failure, that's all. LDH can be elevated in many patients, and like many patients can have acute renal failure associated with liver disease. Wilson disease, one of the easiest thing can be detection of KF ring. Then you can go for alkaline phosphatase, serum copper, all these things can be checked in patients who is having suspicion of Wilson disease. Families should be traced. Now some patients may require liver biopsy, that if you are suspecting malignant infiltration, autoimmune hepatitis, Wilson disease, hepatitis due to herpes simplex virus, these are some of the indication for liver biopsy. Otherwise routinely we don't do liver biopsy in patients with acute liver failure. Elevated aminotransferases like SGOT, SGPT, all these things are feature of acute liver failure. Features of hepatic encephalopathy is very important in to diagnose a case of hepatic acute liver failure. PTNR should be elevated. So SGOT, SGPT should be elevated. Hepatic encephalopathy features should be there, and you should have a prolonged INR. Then we can make a diagnosis of acute liver failure. So if you see the LFT abnormalities in different cases, you can get different types of LFT abnormalities, but here you can just follow this chart so that you will understand what is the type of liver function test you get in acute hepatitis. Other condition it may slightly vary. Now, how to treat acute hepatic failure in your ICU? One of the important drugs we use in patients who is having paracetamol toxicity is N-acetylcysteine. You should remember that N-acetylcysteine is now available as tablets, nebulization, IV. Here you should use IV. Tablet also can be given, but better to go for IV because tablets sometimes it may not be absorbing because of the liver problem. So that may not get absorbed. So you can go for the same protocol what we give in paracetamol toxicity, 150 milligram per kg per hour over 1 hour, followed by 12.5 milligram per kg per hour for 4 hours, then continuous infusion of 6.25 milligram per kg per hour for remaining 67 hours. So, that is one of the protocol. There are different protocols available, oral protocol is available. So, this will be very useful in a patient who is having acute liver injury, but this is basically, this protocol is designed for paracetamol toxicity. We can use it in other types of liver injury also. Prothrombin time will be elevated in most of the cases who is having acute liver failure. The problem with PTINR, elevation in PTINR, it can be treated with FFP, fresh frozen plasma can be given in patients who is having elevated PTINR. But only problem with that is, suppose patient is having liver failure, you can see INR will be slowly elevating 1.5 and next set maybe 2.5. By seeing this, if you give FFP, the sign will be masked. So, now again INR will be 1.1, it has come down. One of the strong indication for liver transplantation is highly elevated INR. So, you will be just masking, by giving FFP you will be just masking the sign of liver failure. You are not treating the condition, you are only treating the symptom of liver failure. So, sometimes it can create problem, but if you are decided to transplant the liver, then definitely you can go ahead with the FFP treatment. Lactose is one drug which is used to prevent hepatic encephalopathy. It's a stool softener, or it can produce diarrhea, it can reduce the pH in intestine, it can reduce the overgrowth of ammonia producing bacteria in the intestine. So, that should be used, and it can produce at least 2 to 4 soft stools per day. So, that is very important. So, lactose can be given oral solution, or lactose can be given lactose retention enema. Rifaximin is a non-absorbable antibiotic. You can use either rifaximin or ceftriaxone to sterilize the gut. So, these are gut sterilizers. They kill the bacteria in the stomach which can produce ammonia. So, either a third generation cephalosporin or rifaximin can be started. Other drugs like L-ornithine, L-aspartate, it is a liver protective tablet, can be given. Maybe some beneficial effects are there, they are not definitely indicated. Branch chain amino acids also can be tried. Fumacinin in hepatic encephalopathy, one of the drugs which can prevent the agitation in patients are fumacinin. So, we can give fumacinin in a dose of 0.2 mg IV over 15 seconds, then 0.2 mg every minute as needed, up to 1 mg total. So, that can be tried. So, sedation, you should be very careful in giving sedatives in patients with hepatic encephalopathy and agitation. Fentanyl can be used for sedation. So, that is a very good drug in emergency room. Propofol can also be used. So, these are you have to read the guidelines how to use drugs in hepatic encephalopathy. Try to avoid benzodiazepines. Fumacinin can be used to reverse the effects of benzodiazepine. So, these things you should remember. So, there is a criteria called as King's College criteria that that tells you whether this patient requires liver transplantation or not. So, ALF due to paracetamol, ALF not due to paracetamol, there are different subsets under this King's College criteria. If patient is fit for transplant according to this criteria, should go ahead with liver transplantation. So, we have discussed about one of the important topic in emergency room, acute liver failure. A patient coming with highly elevated SGOT, SGPT, hepatic encephalopathy features, elevated PTNR should be diagnosed as acute liver failure if they come in short span, and many patients can deteriorate very fast to severe hepatic coma. You can start hepatic coma measures in emergency room itself, but sometimes patient may require liver transplantation. Thank you.